Welcome to the deep dive. Today we're looking into something called radionecrosis. It's a potential issue after radiation therapy for cancer. We'll explore what it is and also, well, a really interesting therapy option.
Yeah, radiation therapy itself is, a huge part of cancer treatment. The goal is always to target the tumor precisely, hit the cancer, spare the healthy stuff around it as much as possible. But even with the best techniques, some effects on normal tissues can linger.
Exactly. And that's radionecrosis, basically tissue death caused by the radiation. And the key thing, I think, is that it's not always immediate, right? It can pop up months, even years later.
That's right. And it can happen even when standard accepted radiation doses were used. To really get a handle on radionecrosis, it helps to understand a bit about radiation physics and biology.
Oh, okay.
Our sources mention two main kinds of ionizing radiation we should probably cover quickly.
Right, let's dive into that. What are they?
So first, you've got electromagnetic radiation. Think high-energy waves. Gamma rays and X-rays fall into this category.
Okay, waves. Like light, but much more powerful. And the second...
That's particulate radiation. So actual tiny particles hitting the tissue. Things like protons, neutrons.
Gotcha. Waves and particles. And how do we measure the dose?
We use a unit called the rad. It basically measures the energy deposited. 1 rad is 100 ergs of energy per gram of tissue.
Okay, they're rad. And this energy transfer, how does it work? Directly or indirectly?
Well, both. Some radiation directly ionizes atoms in the tissue, knocks electrons out. That's direct damage. Other types, like neutrons, are indirectly ionizing. They hit atomic nuclei first, which then release other things that cause the ionization.
Okay, that gives us a good foundation on the radiation part. Now let's pivot to the potential solution mentioned. Hyperbaric oxygen therapy, HBO. The sources suggest it's getting some, well, pretty good results.
It is, yeah. HBO therapy means breathing pure oxygen in a pressurized chamber. This floods the blood and tissues with much more oxygen than usual. And it's being looked at for radionecrosis in lots of places. Soft tissues, bone.
Bone has a specific name, right? Osteoradionecrosis.
Exactly, osteoradionecrosis. And even in the central nervous system, the CNS.
Wow, okay. Wide range. And since radiation treats cancer, there's that crucial question about HBO and cancer recurrence. We need to unpack that too.
Definitely, we'll get into that.
So the mission for this deep dive.
Basically, to really understand radionecrosis, how it develops, what it does, and then explore HBO therapy's potential for managing it, based on what our sources tell us.
All right, let's get into the nitty-gritty then. Radionecrosis itself. The source describes 4 clinical pathological periods after radiation. Can you walk us through that timeline?
Sure. So the first 6 months are called the acute period. During this time, damage is happening at the cellular level in the irradiated organs, but, it might be silent. No obvious signs or symptoms yet.
So the patient might feel okay, but changes are already underway.
Precisely. Then comes the subacute period, the next 6 months. This is kind of the end of the initial recovery phase. But now permanent tissue damage starts becoming evident. The body's initial repair efforts sort of plateau.
Ah, okay. So the hope that things are just bouncing back might fade a bit here. What about longer term?
Right. Next is the chronic period. This runs from year 2 to year 5 post-radiation. Here, that residual damage keeps progressing. The microvasculature, the tiny blood vessels, really starts to deteriorate. This leads to hypoperfusion.
Less blood flow.
Exactly, less blood flow, which then damages the organ's main tissue, the parenchyma, and makes the area less resistant to infection.
It sounds like a cascade, one problem feeding the next. And after 5 years.
That's the late clinical period. So beyond year 5, those chronic changes continue. Plus, you might see signs of premature aging in the tissues that got radiated. And importantly, there's also a potential risk for radiation-induced cancers later on.
It's quite something how this damage can just keep developing slowly long after the treatment's over. Why do damaged cells struggle to reproduce, and how does losing blood vessels make it worse?
Well, the radiation directly damages the cell's DNA, which is, the blueprint for replication.
Yay.
If it's too damaged, the cell just can't divide properly, or maybe not at all. And the vascular damage is key. Healthy tissues need that dense network of tiny vessels for oxygen and nutrients. If those vessels are blocked or gone, even cells that weren't hit as hard directly by radiation can't get what they need to reproduce.
And the source mentioned collagen loss and more fibrosis, like scar tissue, because oxygen levels are low, something like 5 to 10 millimol/HG. Why is that bad?
Right, collagen is vital for tissue structure. But when tissues are hypoxic, starved of oxygen, the body ramps up collagen production. But it's often laid down haphazardly, leading to fibrosis, excessive scarring, And that scar tissue itself can squeeze the remaining blood vessels, making the hypoxia even worse. It's a real vicious cycle.
Okay, let's zoom in on the blood vessels themselves. Swelling, degeneration, necrosis of the endothelium. What does that actually do to the vessel?
The endothelium is that thin inner lining. Radiation damages those cells. They swell, break down, die. This triggers inflammation and thickening of the vessel, well, proliferative endarteritis, necrotizing vasculitis. Basically, the pipe gets clogged and inflamed.
Okay.
And unfortunately, the smallest vessels, the arterioles and capillaries that do the real delivery work to the tissues, they're the most vulnerable to this.
So what does this mean for soft tissues, like the skin, which gets hit pretty often?
Yeah, the skin often shows late effects. Atrophy gets thin, fragile. It's easily damaged, leading to ulcers from even minor bumps, and surgical cuts in radiated skin. They heal very poorly because that underlying blood supply just isn't there. Necrosis can happen in deeper tissues too, from the microvascular blockage.
And it affects mucosal linings too, like in the gut or bladder?
Yes,
Okay.
absolutely. Direct radiation can inflame the gut lining gastroenteritis or the bladder lining cystitis. Interestingly, the source specifically mentions a case of laryngeal radionecrosis in the voice box that was treated successfully with HBO. We'll come back to that.
Okay. And the nervous system, neurons are supposed to be fairly resistant, right? So why does radionecrosis happen in the CNS?
That's a good point. The neurons themselves are relatively tough. But in the brain and spinal cord, radionecrosis seems to stem from this complex interaction between the nerve cells, the parenchyma, and those endothelial cells lining the blood vessels. Again, it looks like damage to the vasculature, disrupting blood flow, and oxygen is a key driver in CNS radionecrosis.
Makes sense. Finally, bone. It absorbs more radiation because it's denser. What happens then?
Right, that higher density means a bigger radiation dose absorbed. This damages the blood supply, especially between the periosteum, the outer layer, and the bone surface. It can lead to bone death. Plus, radiation messes up the balance between osteoclasts, the cells that break down bone, and osteoblasts, the builders. This leads to weaker bone, osteoporosis, and eventually osteonecrosis, bone death. Usually takes months to years.
Are certain bones more prone to this?
Yes. The source lists several hotspots. The mandible, the lower jaw, is a big one, especially after head and neck radiation. It's dense, and its blood supply isn't as rich as some other facial bones. Other common sites are ribs, clavicle, sternum, skull, spine, pelvis, and the top of the femur, the femoral head.
Wow, okay. That gives us a really clear picture of how radionecrosis plays out in different tissues. Let's switch fully to hyperbaric oxygen therapy now. How does it help? Starting with skin and mucous membranes.
Okay, so one study looked at patients who had had radiation to the face and mouth years before. They gave them HBO, typically around 28 sessions, 90 minutes each, at 240 kilopascals, which is higher pressure than normal air. And they found noticeable improvements in blood flow, vascular perfusion, and higher oxygen levels in the irradiated skin and gums. And these benefits lasted for at least 6 months after the HBO treatment finished.
That sounds really promising. Better blood flow, more oxygen that seems to hit the core problems of radionecrosis head on.
Absolutely. The researchers also saw increased blood flow when they applied heat and measured higher oxygen pressure in the cheek skin. It strongly suggests HBO helps revitalize those damaged small vessels and boost oxygen supply.
So, given that, what's the clinical thinking? Why use HBO?
Well, the sources really emphasize that standard treatments often fall short. It's just hard to get nutrients and oxygen into these devascularized tissues. Radiation ulcers are painful, hard to heal. Reconstructive surgery in radiated areas, higher failure rate because the tissue just doesn't heal well.
Right.
Is really the frustration with these limitations that push people to try HBO.
Makes total sense attacking the root cause of poor oxygen and blood flow. But the source says maybe only a third of U.S. patients who could benefit actually get HBO. Why the gap?
That's a really key point. I mean, hundreds of thousands get radiation yearly, and a fair chunk, maybe 5–10%, have serious complications. Yet HBO use is relatively low. It is an approved indication by the Undersea and Hyperbaric Medical Society, usually covered by insurance. So why the gap? Probably multiple things. Lack of awareness, maybe? Both patients and some doctors.
Or maybe limited access to chambers?
Could be limited access to centers, and maybe just needing more education in the medical community about its effectiveness here.
Okay, let's get into the biology. How exactly does HBO work against radionecrosis? The mechanism.
Okay, the core idea is simple. Breathing 100% oxygen under pressure dramatically increases the oxygen dissolved in your blood plasma. This means much more oxygen gets delivered to all tissues, even those with poor blood flow. It can bring the oxygen levels in those starved radionecrotic tissues back towards normal.
And that triggers healing.
Yes. This oxygen boost stimulates collagen production, which you need for repair. And critically, it promotes angiogenesis, the growth of new tiny blood vessels. That helps restore circulation. Studies show you can measure this new vessel growth after about 8 treatments, and it plateaus around 80–85% of normal tissue vascularity after maybe 20 sessions.
That fits perfectly with why it helps non-healing wounds in general. And it helps with bone implants, too.
Yeah, there was a study in radiated rabbit tibius. Using HBO when placing bone implants significantly improved how well those implants integrated compared to controls without HBO. Suggests it could really help surgical success when you're rebuilding bone in radiated areas.
Are there times you wouldn't use HBO or things to watch out for?
Definitely. You generally don't start it right after radiation finishes, concerned it might worsen acute inflammation. Also, it might not work as a purely preventative thing before any damage is obvious. Some vascular damage seems needed for HBO to show a clear benefit. And, critically, while it might help define a tumor area for surgery by reducing swelling, it won't make a skin graft take if there's still cancer underneath. HBO treats the radiation damage, not the cancer itself.
Very important distinction. What about the history? When did doctors first notice HBO might help here?
The first hints were back in the early 70s, around 1973. Then a larger study looked at 378 patients. After excluding dropouts, they found positive results in the 336 who completed treatment. The usual protocol was 2 atmospheres pressure for 2 hours daily, or 1.5 hours twice daily, up to 120 hours total. And they stressed starting it at least 2 months after radiotherapy finished. The conclusion was HBO, combined with other care, definitely helped reduce complications.
So the evidence has been building for a while. The source seems pretty convinced for soft tissue and bone, right? Compelling evidence.
Yeah, I think that's fair. The physiological logic, the lab data, and these consistent clinical results from different places, it makes a strong case for both soft tissue radionecrosis and osteoradionecrosis. There was one 14-year review of 124 patients with soft tissue damage. 94% showed significant improvement with an average of about 33 treatments.
94%. Wow.
Impressive, right? They recommended at least 30 treatments and highlighted the need for better ways to predict who will respond best and more standard protocols.
And it's used in kids, too. What did that Penn study find?
Yes, they looked at 10 children who got HBO for radiation complications. Sometimes prophylactically, before dental work or surgery in a radiated area. Other times therapeutically, for existing vasculitis or osteoradionecrosis.
How old were they?
Median age was 14. And often, there was a long gap, maybe 15 years median, between radiation and HBO. Treatment was typically 2 atmospheres, 2 hours daily, median 30 sessions, and the outcomes were excellent. Complete healing in the prophylactic group, disappearance of signs and symptoms, even new bone growth sometimes in the therapeutic group. So yeah, they concluded it seems safe and potentially very valuable for kids.
That's really good to hear, especially for kids dealing with long-term radiation effects. Okay, let's focus specifically on managing osteoradionecrosis, ORN, in bone. What about basic animal studies?
Well, one mouse study looked at HBO and a growth factor, BFGF, for radiation-impaired bone growth. HBO helped reduce impairment at lower radiation doses, 10 and 20 gray, but not at a higher 30 gray dose. Interestingly, BFGF did help at 30 gray, but adding HBO didn't give any extra benefit over BFGF alone at that high dose.
So maybe HBO is better for less severe damage, growth factors for more severe. What about quality of life in humans getting surgery in radiated areas?
Right. There was a study on patients having maxillofacial surgery after radiation. Those who got perioperative HBO around the time of surgery, reported significant improvements. Better teeth health, less dry mouth, better social contact. This led the researchers to recommend considering HBO to prevent or treat long-term radiotherapy issues in the head and neck.
Okay, now let's really zero in on ORN of the mandible, the lower jaw. The source called it the most frequent serious radiation injury. Why the mandible specifically?
It's probably a few things. Its blood supply is a bit unique, running through dense bone. Plus, for head and neck cancers, the tumor is often right near the jaw, so the bone gets a high dose. And radiation also hurts those bone remodeling cells, osteoclasts and osteoblasts. So healing after any injury, like a fracture, is much slower.
And x-rays aren't always reliable for judging severity.
Correct. You might see bone breakdown, osteolysis, or fractures on an x-ray, but sometimes the images look okay even if the patient has significant symptoms, or vice versa, bad x-rays, but milder symptoms. Makes it tricky.
And the old treatments were based on infection.
Yeah, the thinking used to be that infection was the main driver. So treatments were things like antiseptic irrigation, antibiotics, scraping away dead bone, sequestrectomy. We now know the primary issue is the radiation damage to bone and blood supply, though infection can definitely be a secondary problem. This shift really opened the door for HBO.
And the results with HBO seem good, that Hart and Strauss study.
Very good. They looked at 206 patients getting adjunctive HBO for mandibular ORN. 72% had an excellent response, 10% good, 15% fair. So the vast majority benefited. Only a small fraction were treatment failures. Really highlighted HBO's potential.
And there's that well-known Marks protocol from Miami. Can you give us the gist of its stages?
Sure, it's a staged approach. Stage 1 is for less severe cases, HBO plus wound care, but no initial bone removal. If that works, maybe more HBO. If not, Stage 2, local surgical debridement, removing superficial dead bone, then more HBO. Still no healing. Stage 3, more HBO, then the bigger surgery to resect part of the jaw, stabilize it, followed by even more HBO. And Stage 3R involves early reconstruction with HBO.
Very structured. And it worked well in practice.
Yes, they used it on 268 patients over 8 years, with significant resolution of ORN across all stages. Strong evidence for combining HBO and targeted surgery.
And there was even a randomized trial comparing HBO versus penicillin for preventing ORN after tooth extraction in high-risk patients.
Yes, and the results were striking. The penicillin-only group had nearly a 30% rate of developing ORN after extraction. But the group that got HBO around the extraction, only about 5% developed ORN. Huge difference.
Wow.
Led them to conclude HBO should be strongly considered prophylactically to prevent ORN for dental trauma-like extractions in these patients.
That's huge for dental care planning after head and neck radiation. What about the Toronto analysis?
Their retrospective look at 41 patients treated with HBO found 83% had significant improvement. They agree HBO is beneficial, suggesting mild cases might heal with HBO alone, while severe cases likely need surgery plus HBO. They also stress dental checks, wound care, oral hygiene, and echo the advice about removing bad teeth before radiation and using prophylactic HBO for later extraction.
Seems like a consistent story. What about long-term? Can ORN come back?
Yeah, the long-term follow-up study showed it can recur, sometimes many years later, even up to 231 months in one case they saw. But the overall risk of a second episode after successful treatment seems relatively low, and some chronic stable cases might not need more big interventions.
Good to know. And the study from India?
Also positive. 33 patients, up to 30 HBO sessions at 2.4 ATA, 85% showed improvement. Just adds more weight to the evidence from another setting.
Okay, mandible seems well covered. What about ORN elsewhere? Temporal bone, chest wall, vertebrae?
Temporal bone is tricky thin skin, limited blood supply. Latency can be really long, months to decades. Surgery is common, but one case report showed complete resolution when HBO was added. Chest wall ORN, after breast or lung cancer radiation, a series of 20 cases all recovered. 3 involving osteomyelitis were treated successfully with HBO and surgery, and vertebrae, 4 cases mentioned, treated with HBO and minor debridements, all recovered, and 3 actually had spontaneous fusion of the affected bones.
Impressive.
So while the numbers are smaller than for the mandible, the outcomes suggest HBO is beneficial in these less common sites too.
Seems clear the evidence for HBO and bony radionecrosis, especially the mandible, is pretty strong. Let's move to the CNS central nervous system, starting with radiation myelitis, spinal cord injury. What's the thinking on HBO there?
Radiation myelitis is spinal cord damage post-radiation, often from treating nearby cancers. It involved tissue and microvascular injury, potentially leading to clots and ischemia, lack of blood flow. Theoretically, HBO could help during ischemia by boosting oxygen. But there's that lingering concern HBO might also potentiate radiation effects sometimes, and the symptoms can be really delayed, which complicates things.
Right. A complex picture. What did animal studies show?
One rat study found no clear benefit or harm from HBO. But another, looking at HBO for treatment and prevention, was interesting. The best outcomes, least severe myelitis, were in the group getting prophylactic HBO starting 6 weeks after radiation. The worst were in the group getting HBO and radiation on the same day. Suggests timing is critical.
And human studies, for people who already have myelitis.
One study showed improvement in 6 out of 9 patients. Another saw clinical improvement in 23 patients with late radiation brain vascular issues treated with HBO. A study on 10 myelitis patients found no response if deficits were already established, but improvement if treated within a year of onset, and marked improvement if treated within 6 months. They concluded HBO is useful, but should start 2 months post-radiotherapy. Retrospective analyses show stabilization or improvement in some, maybe up to 66%. There's even a case report with MRI improvement. But yeah, the consensus is we need better controlled studies here.
Okay, what about radiation encephalopathy? Brain injury after radiation, sometimes hard to tell apart from tumor recurrence.
Right. It happens in maybe up to 10% of brain radiation patients, depending on dose and area. Treatments include steroids, vitamin E, vasodilators, and HBO. Bevacizumab is being investigated too.
And the evidence for HBO in encephalopathy.
Source mentions 2 patients improving with vasodilators plus HBO. A study of 10 patients with confirmed radiation necrosis, RIN, found initial improvement or stability in all with HBO. Most survivors showed clinical and imaging improvement. The authors felt HBO was an important adjunct to surgery and steroids for RN. There are also case reports of good responses after gamma knife radiosurgery, with lesions shrinking or disappearing on scans. One case improved with HBO after steroids failed. A retrospective review of 10 patients showed subjective, clinical, and radiological improvement in most, but results were less consistent for nonspecific delayed injuries.
Finally, for CNS, radiation-induced optic neuropathy, RION. Sounds devastating.
It is. Serious vision loss complication after head neck radiation, especially with doses over 50 J cumulative or high single doses near the optic nerve, can happen years later. Painless vision loss, field defects, pupil issues, color vision problems, thought to involve vascular blockage, demyelination, free radicals, DNA damage, blood-brain barrier issues. Prognosis is often poor, no standard effective treatment. Steroids, free radical scavengers might help acutely, but long-term impact is limited.
And HBO for ion? Sounds like mixed results again.
Yeah, it's mixed. One series of 13 patients treated with HBO and steroids showed no vision improvement, but other single-case reports have shown visual recovery with HBO alone. One after radiosurgery for Cushing's disease had partial recovery. The source highlights another case. A 78-year-old woman who improved initially with HBO alone could walk again. Deteriorated, but then had subjective improvement with a second HBO course. An MRI showed resolution of optic nerve enhancements.
So still uncertain there. It really seems the CNS evidence is less clear-cut than for bone and other soft tissues. Let's move to soft tissues elsewhere. Extremities, arms and legs.
Right, these are often non-healing wounds in old radiation fields, maybe from skin cancer treatment. One study had 17 patients with these wounds treated daily with HBO. 11 healed completely, 1 improved. That's about a 65% success rate. But the 4 who didn't respond ended up needing amputations. So while HBO is valuable as a first try, failure can have serious consequences.
Okay. Head and neck soft tissue necrosis. We touched on the mandible, but general soft tissue.
Yeah, radiation damages healthy tissue and vessels there, making surgery riskier. HBO helps by boosting oxygen, promoting angiogenesis and fibroplasia, maybe some antibacterial effect too, one series. 48 patients with post-op wound breakdown in irradiated head neck tissues, all improves with HBO, except one who had a fatal aspiration. Another study compared 15 HBO-treated patients with non-healing post-surgical wounds to historical controls without HBO. HBO group had faster, more complete healing, fewer severe complications like hemorrhage. Conclusion: HBO has a significant positive clinical effect.
Very encouraging for head and neck surgery patients. What about the larynx specifically, the voice box?
Laryngeal radionecrosis. Uncommon, but serious. Usually months post-therapy. Hard to tell from cancer recurrence pain, swallowing problems, obstruction. Ischemia and hypoxia play a big role. Biopsy often needed. Conservative treatments exist: humidification, antibiotics, steroids. HBO is emerging as a key adjunct. One study, 8 patients, advanced laryngeal radionecrosis. 7 improved markedly with adjuvant HBO. Only 1 needed a laryngectomy. Better than older series without HBO. Another series, 9 patients, mostly severe necrosis. All kept their voice, tracheostomies removed, fistulas closed after HBO. They called it a valuable option to save the larynx. Case report 2. Elderly man avoided laryngectomy thanks to HBO. Seems like an effective conservative choice.
They're really valuable for preserving function. What about the abdomen and pelvis? Radiation is less common there.
Less common due to organ tolerance, but used for some cancers. Complication risk exists, maybe 20% for whole abdomen radiation for ovarian cancer. Serious issues often show up late, 6 months, due to vascular compromise, hypoxia from fibrosis. Sometimes need surgery. A review of 44 patients found an 81% success rate for healing abdominal pelvic radiation injuries in those who got at least 20 HBO treatments. Reports also show HBO improving malabsorption from radiation enteritis and healing severe hemorrhagic proctitis in one case where the patient refused colostomy.
So useful there too, even if less common. Now, hemorrhagic cystitis bladder bleeding, that sounds awful.
It is. Recurrent bloody urine, urgency, pain. Biopsies show swelling, abnormal vessels, telangiectasias, bleeding under the lining, artery damage, muscle scarring. It's progressive, doesn't fix itself. Old treatments managed symptoms but didn't heal the underlying damage and had side effects. HBO, by improving oxygen and angiogenesis, targets the root cause. Multiple studies show HBO stops bleeding in many patients, sometimes fairly quickly. Longer courses show symptom relief, even reversal of tissue damage. Largest series reported complete marked improvement at about 74%. Costs compared favorably too. Big retrospective analysis. HBO safe, effective, reduced transfusion needs. So strong evidence, though yes, lack of definitive large RCTs is noted, but seems like a very favorable effect.
Huge potential quality of life improvement and radiation proctitis, rectal inflammation, often after prostate cancer treatment.
Yep, another known complication. Bleeding, diarrhea, incontinence, pain. Case reports show severe hemorrhagic proctitis healing with HBO. Prospective study. 14 patients with non-healing pelvic soft tissue necrosis, including fistulas, all healed after HBO. Series of 14 with chronic proctitis. 64% had complete or substantial symptom resolution with HBO, plus improvement seen on sigmoidoscopy. Conclusion. Consider HBO. Generally, 50% seem to get partial or complete symptom resolution. Needs more trials, but looks promising. One study looked at 19 patients with both cystitis and proctitis. Hematuria resolved completely in 81%, partially in 18%. Rectal bleeding resolved completely in 50%, partially in 25%. They suggested HBO is appropriate after simpler things fail.
It's really striking how many different soft tissue problems across the body seem to respond well to HBO. Okay, let's tackle that crucial concern. Does HBO make the original cancer more likely to come back?
Right. Critical question. There were some very old reports of occult cancers showing up after HBO, leading to caution. But our source says there's no solid evidence backing that up now. In fact, mouse studies with transplanted cancers showed HBO didn't make them grow faster or shrink. Some studies even hinted at an inhibitory effect. Animal oral cancer models had mixed results. Fewer tumors with HBO during induction, but maybe larger ones if given during proliferation. Suggest complex timing effects. Importantly, most hyperbaric practitioners surveyed don't think HBO promotes cancer.
Okay.
A literature review found conflicting results. Some studies suggest suppression, others no effect. Might relate to free radicals generated by HBO affecting different tumor cells differently. So overall, the current evidence doesn't strongly point to HBO increasing cancer recurrence risk when used for radionecrosis. But of course, careful monitoring is always needed with any cancer history.
That's reassuring. Okay, as we wrap up this deep dive, can you give us the main takeaways on radionecrosis and HBO?
Sure. Radionecrosis, a challenging late effect of radiation. HBO therapy shows considerable promise, especially as an adjunct to surgery for things like mandibular osteoradionecrosis and laryngeal necrosis. The evidence for neural tissue, maybe excluding the brain, is less striking. But for radiation cystitis and proctitis, HBO also looks quite beneficial.
And we should acknowledge the limitation, the lack of large, definitive controlled studies for all these conditions.
True. The variability of the condition and difficulty controlling other treatments makes those studies hard to do. But importantly, most of the 74 publications reviewed did report positive outcomes with HBO, especially compared to the often radical surgeries or limited drug options, which often lack RCT evidence themselves. Plus, you have that prospective assessment of over 400 patients, 94% positive outcome, and a registry analysis of over 2,500 patients showing high rates of improvement, and systematic reviews indicating benefit in head, neck, and rectal injury and preventing ORN post-extraction.
So while we want more gold standard evidence, the current weight of evidence seems pretty strongly in favor of HBO for many of these delayed injuries.
Absolutely. And that leads to our final thought for you, the listener. Given the strong supporting evidence for HBO, despite the need for more trials, maybe exploring combinations with growth factors, what other kinds of radiation injury might benefit, and what are the biggest hurdles to actually doing those large-scale controlled trials we need in this field? Something to think about as we work to improve care for people facing these long-term radiation effects.